because we come from communities where the truth doesn't always reach the headlines, but it lives in what we face every day. This is Changing Trends and Times, bringing clarity and context to the issues shaping our lives right now. No spin, no distractions, just real talk rooted in real impact. Now, are you ready to lean in and bring your voices into the conversation? Then, allow me to introduce to you a man committed to asking the questions that matter and breaking it down so we all understand. Your host, Charles King.
Good afternoon, ladies and gentlemen. To understand why Black Americans remain one of the most underserved populations in mental health care, we must first reckon with what mental health systems once did to Black people. Because this is not a glory to neglect alone. It is a story of active weaponization. In 1851, a Louisiana physician named Samuel A. Cartwright stood before the Medical Association of Louisiana and presented what he called groundbreaking medical discovery. He had identified, he claimed, a mental illness unique to enslaved Black people, a disease he named drapetomania, derived from the Greek drapetes, meaning runaway slave, and mania, meaning madness. His diagnosis, chillingly simple: if an enslaved person desired freedom, if they attempted to run, that desire itself was a symptom of mental illness. The human instinct to be free was reframed as pathology. Liberation was a disease. The cure: surveillance, forced submission, and physical punishment. Let that land for a moment. A man looked at another human being's desperate hunger for freedom and wrote it into a medical journal as a disorder. That was not fringe thinking. It was published. It was reprinted across the South. It was used to justify the recapture of enslaved people as a matter of public health. Medicine became a weapon of the plantation. This tradition did not die with slavery. More than a century later, in the 1960s and 70s, as Black men marched in the streets demanding civil rights, psychiatry once again turned its intrudements against Black bodies. Schizophrenia diagnosis among Black men skyrocketed during this era, disproportionately applied to those involved in civil rights activism. The American Journal of Psychiatry ran advertisements for antipsychotic medications featuring imagery of angry Black men, directly associating Blackness, protest, and resistance with mental illness. The message was unmistakably activism was pathology. Anger at injustice was a symptom to be medicated, not a truth to be heard. This phenomenon, now known as protest psychosis, documented how the very language of psychiatry was recruited to silence a freedom movement. These are not distant footnotes. They are the foundation of a distrust that persists today. Black Americans are 20% more likely to experience serious mental health challenges than the general population, yet they are significantly less likely to seek or receive care. The reasons are not mysterious, they are historical. When the system that claims to heal you has a documented record of using diagnoses as a tool of control, of punishing your humanity with the prescription, of labeling your freedom as madness, you do not trust that system. That is not irrational. That is wisdom earned through suffering. Consider also the cultural narrative of strength imposed upon Black men in particular, the expectation that they carry every burden without breaking, without asking, without showing pain. This is not simply culture. It is the scar issued of a system that penalized vulnerability in Black men for centuries. To show weakness was to invite exploitation. Stoicism was survival. The problem is that survival strategies outline their context, and what once protected now isolates. Today, suicide rates among young Black men have risen significantly over the past decade, a crisis that has been met with far too little urgency. The silence around mental health in underserved communities is not a character flaw, not a cultural deficiency, not a failure of will. It is the direct, mind measurable consequence of centuries of systemic abuse, medical betrayal, and structural abandonment. We cannot talk about healing without first telling the truth about the wound. Now, I just wanted to give you guys this reflection as we get into this show. And I want this to sit with you for a second, because this is part 2 of healthcare and underserved communities and the truth and the issues of mental illness, because it's a real thing. And so as we get into this, I just want to let that sink with you guys first as we move into this opening, because we were taught that strength means silence, that teaching is costing lives. Let me ask you something before we get into the data, before we get into the history, before we get into any of the research. Think about your life. Think about the people you love. Now tell me, how many of them needed help at some point and didn't get it? How many of them were struggling with something nobody talked about? How many of them sat across from you at the dinner table carrying something so heavy that you could almost feel it and nobody said a word? If you're Black in America, if you're brown in America, if you grew up in a community that learned survive on very little, I already know the answer. We all know someone. Most of us know many someones. And the tragedy isn't just that they suffered. The tragedy is that we were taught the suffering was supposed to be private. We were taught that strength means silence, that our business stays in the house, that you pray about it, that you push through, that real men don't cry, that good women hold the family together, that airing your pain is weakness. And I want to say as clearly and as directly as I know how, that teaching is killing people. Not metaphorically, literally. The silence around mental health in our communities has a body count. It shows up in the rising of suicide rates among young Black men. It shows up in the untreated depression that becomes addiction. It shows up in the PTSD that never gets named, never gets treated, never gets path to healing, because nobody in the neighborhood knows what to call it or where to go. And here, what I need us to sit with, even with someone who gathers the courage, the enormous against the current courage to say, I need help. The barriers are staggering. No insurance, no Black therapists within 100 miles, a mental health system that doesn't speak your language, literally or culturally, providers who have never sat in a Black church, never walked through a Black neighborhood, like yours, never felt the specific and particular weight of being Black in America, and who can't begin to understand what you're carrying when you walk through their door. So that's why we're here today. And we're going to sit in comfortable silence. We're going to break it on purpose, loudly, with evidence, with history, and with care for every single person listening who has been waiting for someone to say, your pain is real, your struggle is valid, and you deserve care. So here we go. As we get into this, we're going to talk about mental health in the best way. We're going to talk about mental health as to how we can best benefit our community. So the first thing I want you guys to understand is when we talk about the scope of mental health crisis in underserved communities, you know, that could be Black, Latino, Indigenous, and rural Americans. They face significantly higher rates of mental illness. Okay. And that mental illness, it gets so to the point that, you know, it runs rampant. It causes people to act out. You can't be controlled. There's no medications, and people are trying to find old remedies to try to solve this problem. But this problem is one that runs rampant because this is what we know in our communities. This is what people know in our communities, because going to see a therapist that does not look like you, or going to see or to seek mental health counseling in general, is one that's frowned upon, but also done with pause. And it's done with pauses because, you know, when you think about what I started out in the beginning about the historical context is what makes so many people not want to seek mental health counseling, because the fear is that this medication that these people are going to give me are some things that's going to make me worse. It's going to make me see things. It's just going to make me be totally different and not be the person who I am. And so as we think about that, you know, that does not mean that people still might not need mental health care, but it's just the whole premise that we have to get it. We have to seek counseling in some shape, form, or fashion. And so when we talk about that, and we talk about that divide, we talk about that racial trauma, you know, where we can talk about, you know, whether you're Black, brown, Indigenous, or you're living in a rural area, that, you know, you get this race-based traumatic stress. And so when you get that in itself is a real thing. And that's one of those things that causes lots and lots and lots of issues itself. And so when that happens, okay, this is where, yeah, you know, we do need some mental health care. But the problem is, where do we trust, or who can we trust that's going to give us that help? And this third point that I want to talk to you guys about is the shortage of culturally component mental health providers. Now, approximately 4% of psychologists in the United States are Black. Latino psychologists make up roughly 6%. Indigenous mental health providers are pretty much non-existent. So when we talk about Black, brown, and Indigenous people, again, if the numbers are that small, how do we find providers that we feel like we can trust in order to get that help? Now, to help us with this, we have a guest that's going to give us his analysis, you know, and his take on psychology, mental health therapy, and how this actually works here in our communities. We're going to introduce to the stage Dr. Leon Malsby, that's going to give us his thoughts on this. Hello, Dr. Malsby.
Good afternoon. How are you doing today?
I am doing just excellent, and I want to thank you for being here to help us get through this. And as we get through this, I want to ask you, before we get into, your diagnoses and the things that you can provide for us, is there anything that I missed, in that opening to introduce what we're going to be talking about?
Yeah, I mean, I think one thing as you were speaking about getting therapy in some sense, obviously we know the Black and Brown communities are typically heavily rooted in some type of like faith-based community, but often realizing that sometimes our pastors like that, they're not, you really want to make sure that whoever you're seeking support from, because trauma is so generational, has gone through decades, you want to make sure the person you're confiding in really has a skill set to address everything. So
Mm,
I think that's one thing I'd make sure is like, while a pastor is very useful, there are often times where there are some discrepancies of what their advice and, the modalities that they're coming from one lens, but with therapy, it has multiple, if you're seeing a psychoanalyst or a therapist, they can provide a global perspective. So I think just being very intentional about who it is we're seeing to make sure we're trusting someone with our mind, the same way we're very sensitive about who we trust with our money with a bank, we want to make sure the same thing is with our mind and our body. So I wanted to add that piece to it as well before we get started.
So, which of these three areas should we start first with? The scope, racial trauma, or provider shortage? Do you feel is the most urgent to address first?
I would say probably I would say the scope really of mental health. I think that's a major thing. And I think they're all obviously very interconnected. But I think in terms of within our underserved communities, it's not that mental health is not present in the Black and Brown communities. It's just that when we do see some of these symptoms and behaviors, we're quick to dismiss it, or we're also fearful to kind of speak on it because we feel like, oh, we're going to be labeled crazy, as opposed to going through something that are just chemical imbalances. And so there's a lot of people in our community that are not trained or taught to like see certain things. And how do I provide like more of a listening ear to see what's going on with this person? Especially we know like we're talking about mental health, but also we know like mental health diagnoses is so and PTSD is so rooted in the Black and Brown experience. We have higher morbidities with certain conditions like HIV. We have higher incarceration rates. With that alone, comes with some things. Obviously, like a lot of PTSD comes with incarceration, pre and post and during. And so I think even like some of like the living circumstances of individuals, like that is traumatic. We see a lot of people who end up getting in children's services and having the children take away, like a lot of those are Black and Brown communities. And oftentimes the services are supporting us to how do we care for our family and loved ones in a way that's equitable. So we find that we're more interactive with these systems, which also adds more trauma and obviously creates a mistrust that becomes generational as well.
So, as we dig deeper into the scope, when we talk about a mental health crisis, what does that actually look like on the ground in underserved communities?
It looks like individuals who are severely depressed, who are not on medication and not being diagnosed and fearful going to their to any doctor really. It could be individuals who are presenting in the emergency room or urgent cares with blatant mental health conditions, but being misdiagnosed. It could be people who are struggling with anxiety or aggression and not sure what the root of that aggression is for them. It's often like we see these people like who are walking around with like blatant mental conditions, but just not being treated for it, and we see how that spirals. And we wonder, see Black women, walking around with postpartum depression and not being treated, and then we see obviously the unfortunate part to where sometimes if they take their own life, suicide rates are really really high in the Black community, and so and the first thing people say is, "Oh, I didn't know this person would be capable of this," but we also were blind to these um, very blatant symptoms. And like the most extreme, we'll see some people. Obviously, we see people who are unhoused who may be experiencing clear symptoms of like schizophrenia and things like that. And we don't really chalk up to how we can support this person or what's really the root cause of it. We just think, oh, because they're unhoused, it's a natural part of it. But that's a mental health crisis. And again, being unhoused is a cycle of that just permeates with mental health because to constantly be in survival mode when you're unhoused and not feeling safe, it just continues to exacerbate the mental condition as well.
So, for those of you that are just joining, we're doing part two of our series of healthcare and underserved communities, and we're talking about mental health today. And we have Dr. Leon Malsby with us, who is a licensed therapist that's going to help us as we go through these issues today. So, Dr. Mosby, what indicators or patterns do you see most often that tell you a community is in mental health distress?
Um, One, when we see like obviously with the affordability is very high, we see that's obviously a huge thing. How people live, the social we call it like the social determinants of health, right? How people access mental health, how people have appropriate food. Like if you're in a food desert, that's a symptom of a mental health crisis. Obviously, the kind of schools people are attending for their children, jobs, right? If there's no reasonable jobs in the area and they're having to commute, but it's a further commute, and obviously the social economic status is low as well, it becomes a issue as well. So these things we know tie into our mental health. It's not just one thing, but it's a compounding issues that end up becoming a barrier for people to access their mental health. And so also even having like equitable and an appropriate representation in the mental spaces. So if you are going to an urgent care or hospital or mental health hospital, do those doctors or those psychiatrists or those therapists look like you? If not, do they may not know your lived experiences, so it makes it harder to really um, um, feel comfortable to unload some of those things to that person. So it's a
So,
layered approach. It's layered.
so Dr. Mosby, as we started out, where I had to give the historical text, and I did a reflection from the historical text about Black and Brown and Indigenous communities and mental health. Can you tell us what is the importance of actually seeing and seeking therapists that look so much like you when getting that help? What is the real reason that we have this issue that we have?
I mean, the real reason is, I mean, if you see a therapist that looks like you, a black or brown person, it automatically calms your nervous system a little bit. For most communities, there is a caveat with that a little bit, but for most communities, they feel comfort in knowing this person understands my lived experiences, so I don't have to over explain my circumstances. If I start making certain references to, let's say, for instance, so, growing up, we were eating bologna sandwiches, you're not confused by that, or explaining some of the cultural things that we know to be true. It's a comfort there. It's a language that's automatically there, and we build trust with it. So I think that's the biggest thing is less explaining, especially when you're talking about. Because one question I love to ask individuals, especially when I'm doing like my groups with the patients, is like, what was your understanding of mental health growing up? What did your parents, what did your loved ones say to, what did you know about mental health and substance use growing up? And from that, I then asked, well, how does that impact your understanding of your own mental health condition that you're currently dealing with? To see that often there's a parallel. So if their family's growing up, you don't believe in certain things, naturally as you get older and you're in your 20s or 30s or 40s or later, you'll see those things coming up as well. So I do ask that question because I like to get the insight about what people are in the room and their experiences growing up. But if you're growing up in spaces and you're talking to a provider who's also like you're more comfortable disclosing certain things. So it's less um, frightening and less ambiguous about if they're understanding your lived experiences. Because that's what we're asking patients in therapy. You're asking their lived experiences. And so you're having to unpack their trauma and unpacking their different things that have happened to them, even their understanding their diagnosis. You want that you want that patient to understand like the therapist is on the same page.
So, that number that I gave about the suicide rates, what can you tell us more in depth about the suicide rates that have now increased in the Black and Brown and Indigenous communities when it comes to mental health?
Yes, I mean, and even recently I was on a training where we learned that even like women have started doing more. We often think of women doing suicide like through like more of the passive ways, but we saw recently in the data that women are now doing more like using guns as a final way of committing suicide. So things are evolving. I think that the pandemic has definitely opened up a lot for individuals in terms of these numbers, and I think identifying that there may be some um, things going on mentally that they are struggling with, especially when people are forced to quarantine. But numbers are still very high. Numbers of people are still feeling isolated, and a lot of it is still rooted in the stigma, and sometimes it's internalized stigma in terms that they don't feel comfortable saying certain things. I often say that, especially when we talk about suicide, and it being so deeply rooted with like bipolar and depression, it's like it's oftentimes people think that they're alone in a situation. There's no way out. And so how we bring that down is by having conversations. So if more people are talking about the different depressive states, anxiety or mental conditions, substance use, you see that there are other people going through the same thing, and it's not just you. You may be the only one in your social circle, your family circle, but there are people who are struggling with the same type of ailments that everyone's going through it. So there's more community than there's not. I think oftentimes we see that people feel like it's the only way out because they feel like no one understands them. But oftentimes, like there are plenty of people who may understand them, but they just don't get the opportunity to kind of like share their story. So having more conversations about our trials and tribulations, I think that should bring that number down a lot because people understand like you're not in this alone.
Now, you mentioned something in your response that kind of caught me, and I think that a lot of us need to understand. Where most of this really kicked off a real serious downfall is the pandemic. Can you tell us, with the pandemic, and we were sheltered in place for like a year and a half, 2 years, and there's no contact other than doing Zoom and things of that nature. Can you tell us how did that affect and what happened with that changed the mental capacity of all our people?
Yeah, I mean, I think it's twofold. I think on one end, you have people were dying at high numbers. And so when people are dying, it was a very it's a smaller section, a smaller sample size of what we saw with the HIV epidemic. People were dying left and right. And so when we think of the pandemic, we think of like grief as one obviously emotion people are going through. Like, and you're not able to say goodbye to these individuals, and like you don't know who's going to be next, and you could be next, and you don't know, we had so many questions and we didn't have as many answers. And so I think a lot of the pandemic experienced a lot of grief and no closure with the grief on top of individuals having to face their own morality about like how do I keep myself safe? How to keep my children safe with this thing that we can't see? And then obviously, with all that happening about people passing away and going through grief, and also individually, how do I protect myself? There's this added layer that drastically impacted Black and Brown communities because like they're saying I need this vaccine, but yet historically the government and medicine has not been kind to our people. And my parents and my grandparents and my aunts and uncles and people are saying, I can't trust this vaccine, but yet other people are getting it. And so, we saw a lot of like, I would say like the deaths and the higher hospitalization rates were higher in Black and Brown communities because we also had lower uptakes of that vaccine early on.
Right.
And so it was so many different things happening at the same time. But I definitely think grief and obviously self-preservation were two of the major things. And also it's like now there's this medical mistrust. And what I often said when I was working here in California, work with adolescents and trying to get them to take the vaccine, they will often say, well, my mom doesn't want me to get it, but they couldn't quite say as to why. And so it's a generational thing. And most of the parents wouldn't be able to say or name some of the studies or some of the people who are wrong medically, but they just know I can't trust what's in this medicine. I can't trust, healthcare systems because historically it's not served us. And they don't know the context, but they know the feeling around it.
But what I think validates what you're saying here, and of course, I don't know all of the real raw data, but when you think about the people that not only were sick, because now you've got people that are having these side effects, they calling it long COVID, and they don't know what's happening where people can't breathe, and they're having all these things happening, and it's brought the health all the way down. So just when we think about that in particular, you know, how is it or what is it that we can actually do, especially from the mental health perspective, that we have to do something to help our people that need this help, that could be facing some things that it might not be as serious as you think, but if you're having some kind of mental breakdown, you need to get some help. What can we do to get these people to get this help?
I think understanding, like, it's really normalizing seeking services. I mean, because it's not saying that there aren't Black therapists, that they're not Black social workers, Black psychologists. They're out there. Oftentimes, we have to look for them and be open to that, but we have to be normalizing the situations. A lot of times, people think it's abnormal to seek out support, but with kind of like it's okay. And I think one thing that did come from the pandemic, I think there were a lot of Black celebrities. I'm thinking mainly of Taraji P Henson, but there were several other ones that were normalizing mental health service, seeking mental health and talking about, well, my therapist says this, or kind of vocalizing their experience with it. And then people, oh, you see a therapist? Well, yeah, everyone should. And so that was a huge thing I think that was a blessing from the pandemic, because it opened up a lot of people, because nobody was immune to the pandemic, and so people were all impacted. And so hearing how people turn to therapy as a way of coping with it was really, really major. So I think normalizing these conversations about mental health services, and even people sharing their different experiences. I know I follow a few people on social media, and one in particular, he details some of the lessons he's learned in therapy. I'm like, that's powerful. That's more powerful than he probably knows. But if things could be applicable to other people's lives, but also like, well, if this person is getting this information from a therapist, maybe I should try it.
So, still sticking with the scope, how do poverty, unstable housing, and limited access to care compound mental health challenges?
If When we're struggling with our social determinants of health, we look at Maslow's theory in terms of like, you're not going to prioritize your mental health if you can't put food on the table. If you're worried about maintaining your house and your bills, like, your mental health will come to the back burner. And that's something we really, really know. And patients will tell you all the time, even patients I work with chronic conditions, they'll be like, I'm not concerned about this medication. I'm concerned about how I'm going to eat tomorrow. And so really having a system that supports all these different needs is really critical, because we understanding like the lived experiences. And you might have a therapist who may be like of a wide experience, and they're trying to talk to their Black clients about come to the appointments, so you miss certain sessions, not realizing like you got a child in daycare, you got a job that's overnight, you have other responsibilities, maybe taking care of a parent. So their main concerns are those. That appointment they miss is not on their radar. And so unless you're going to provide support for these other issues or other areas in their life that they need support in, they're not going to prioritize their mental health. And we've seen that historically for decades within the Black community, especially Black and Brown community. They're more focused on how I take care of my loved ones as opposed to myself. And then we think of generationally, then you see like your children are seeing how you are working two jobs and doing X, Y, and Z, but it's also burning you out. And so they start to adopt those same habits. So it becomes a generational pattern often until someone breaks it.
So, how would you describe the scale and urgency of the mental health crisis in underserved communities? And why do you think it has taken this long to get this level of public attention?
I think it's a major, still a crisis in the Black community and the underserved communities. It still needs to be addressed. And we think about the trauma that's being impacted by individuals of Hispanic culture who are now being, raided by ICE and concerned about their loved ones. Like, that causes a long-term trauma. And so I think that why it has not been on the forefront for people's minds is because you have to also think about, it's not just mental health services, because that has always been available. It's how the healthcare system is, how the housing system is, how, financial stability is, all these different things play a role in it, and that's all typically governed by government, and so we always can't change where we live, and we can't always make more money. So the cards are always stacked against us. And the dealer of those cards is the government, and these systems, they're not going to address the mental health crisis because, their output is impacting the input of the mental health. So I think for so many people, like, if you don't have people in power, which was really critical to understand who you're voting for, if you have people in power who are having your, whole person
Right.
in mind when talking about making policies and changing laws, then you'll always be at a disservice. So I think our mental health has always been at an issue, but it's often because we're dealing with these other things that we get no support from.
So I wanted to actually move over to another part of what we're going to be discussing. But before we move over, is there anything that you like for the audience to get in a summation as to when we talk about the scope of mental health, something that they should be thinking about and focusing on?
Yeah, I think one thing is like, how do I know if I need to see a therapist? I think anyone should be seeing a therapist. There's life experiences, adjustment to certain things as we're evolving that we should be mindful of. And it's always healthy to have an unbiased person to talk to. I often say when you're looking for a therapist, it's almost like you're dating. So you want to make sure that you have the right therapist that fits you. And so there's often like questions you want to ask in terms of like their style, kind of obviously identify certain things you want to work on and see if they can work with some of those things. If they historically have patients with some of those similar concerns or life circumstances. But
Mhm.
all this normalizing the experience of seeing a therapist is not what it was before. Like there's nothing wrong with you to want to see a therapist. If anything, it makes us more stronger and resilient.
So let's move over and let's talk a little bit about the racial trauma as a public health crisis. If you don't mind, first, if you could walk us through the concept of racial trauma, what it is, what it looks like, and why it matters that we recognize it as a distinct public health crisis.
Yeah, so when we think of public health, we think of like the whole person. So, I'm thinking of like mental health and our physical health, right?
Right.
Racial trauma, historically, we know about slavery and what that impact has had. But I think even now with these systems that are rooted in racism,
Mhm.
we often get the short end of the stick in most of these situations and healthcare systems. So whether it be medical, again, we know Black women are disproportionately impacted with um, 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 Black maternal health, where they're dying at high rates. We know that we have high rates of suicide. We know that we have high rates of hypertension and high cholesterol in our community. Cancer, we know that Black men have higher rates of prostate cancer. And it's not because like these conditions are just more adept to us, it's because of the circumstances. What food can we eat? Do we have healthy grocery stores that are affordable? In our areas? Do we have healthcare systems that are, accessible to our insurance? Do we have, is the waiting times, a few months to see a primary care doctor when you need to see it more frequently? So racial trauma is like how we experience this thing called life as Black individuals, as brown individuals, while we're not currently going through slavery, but it has a lasting impact on us. And so there oftentimes we're mistreated because we're Black, and that's a trauma in itself. Where we're not told that our experience is valid. We might come in there saying certain things like, I'm experiencing this pain, for instance, and they may downplay it, or maybe talking about certain things that could be treated through prevention measures, and they're going more extreme because they're not, let's say, listening to that patient, or they're fearful to ask some of the hard-hitting questions that typically a Black provider would ask. You think of like um, if someone's talking about these different things like, I'm just feeling really depressed, like, are you going to do the assessment for depression, or are you just kind of like, oh well, just take it easy, take some days off of work, not realizing they can't even take a day off of work because they can't afford to. And so that's all rooted in like this racial trauma of like how we're experienced as individuals from our counterparts.
Mm. So as you said, racial trauma is not just emotional; it's physiological. Can you explain how racial trauma shows up in the body?
Yes, and oftentimes we talk about like the Black woman schema, where like Black women have this thing where they survival mode, right? And it's like oftentimes people are functioning with high levels of anxiety, high levels of trauma, and for them it may feel very normal, but we know it's like obviously like the palpitations of the heart. They may feel very tense around the shoulder areas, obviously like their facial expressions may be very tense as well. It often might be like stomach, clenching the stomach sometimes, and like obviously leads to sometimes like ulcers and things like that. It's really a tightness and an uneasiness. It could be racing thoughts, right? It could be sweatiness and constant worry because you're trying to figure out how you're gonna make ends meet, or you're trying to figure out, even racially, if you live in a certain area, like what's gonna happen if my son leaves the house at 9 o'clock at night or 8 o'clock at night, will they come home? If my loved one's going to the hospital, it's that gut feeling like, will they come back to me? You know, you may go into the hospital for one thing, and next thing you get a phone call saying your loved one has passed away. So it comes up in like, our mental state in terms of our thought process and overthinking and or just having a lot of anxiety. And it also comes up physically in terms of the heart palpitations, like racing heart. It could be sweating, could just be like shakes with anxiety. It shows up so many different ways. Tightness in the stomach. We're constantly like worrying about what's going to happen. Absolutely.
So, how does racial trauma differ from traditional definitions of trauma in clinical settings?
Racial trauma is sometimes also compounding with regular trauma, especially think of Black and Brown people. And so, naturally, again, racial trauma is because it's a trauma that comes from like just being that particular race and all the things that come within that and how people treat you because you are that race, right? So not believing and things like that. The regular trauma is just an added layer to it. You have the emotional trauma, you have like, childhood trauma, sexual trauma, all these forms of abuse that add to it. And so oftentimes racial trauma is like the sometimes could be the gateway to it, or it could be another one, but it's just compounding. It's an added layer of trauma. We think of folks and children who are in the foster care system. That's a form of trauma. And then the secondary trauma may be like because they're a Black child in the foster care system, they're treated this way.
Mm. So, what are some everyday experiences that create chronic racial stress for Black and Brown communities?
The media, when we see that people are being shot, or the protocols not being followed, or being more, the law enforcement being more aggressive to people of color than they would someone else who's not of color. We think of a lot of things like there was the church shooting in the Carolinas a couple of years ago, I think almost 10 years ago at this point, and how it was a Black church and a white shooter, and the fact that that individual who was the shooter was able to come out and was arrested and was, put in the car and stuff like that very calmly. But and so from in the Black experience, there's this fear and this feeling like if that was a Black shooter, that shooter would not have been able to make it to the cop car. And so it's that understanding that life is not fair, but seeing in real time also adds to these different situations. It's in the healthcare systems where you're trying to talk about your experience and you're not really heard. Or you see people dying, and it's like, well, I don't want to go to the hospital because I feel like if they were treated that way, how am I going to be treated as a Black person as well? It's being pulled over by a cop, and trying to ask very simple questions and being given attitude or being told to comply and not ask questions. So you're not able to, have the same experience that individuals who are white may have as being pulled over by law enforcement. Even in the workplace, there's a lot of like hostile work environments because of people's skin color, because people are Black. There's condescending tones, obviously being passive for promotions. It could be micromanaged, to name a few.
So, why do you believe racial trauma should be classified as a public health crisis rather than an individual mental health issue?
Because I think of how deeply rooted racial trauma is. I don't think, some things can be combined, but I think that's a special thing that will take more than just a mental health therapist to unpack. It really requires like how do we change as a society to address racial trauma? It's not just, oh, let me see a therapist, get some medication, and that's going to be it. That's how we can deal with anxiety, right? And we can learn coping skills and things of that nature. But how do you cope with being Black?
Ooh,
You don't just, like, cope with it. I mean, a lot of people are
yeah.
resilient and they deal with it, but, it's a different thing. Like, you need to change the entire system around this lived experience, which it also takes the allies to the Black and Brown communities to also change some of these policies and support the policy changes. So that's really where it takes, as a global issue and not just like a mental health component.
So, can you give us a summation, of racial trauma as a public health crisis before we move to our final part, of what we're going to be discussing today?
Yes, I mean, racial trauma again impacts us from as a whole person because of our lived experiences and those of our ancestors. And because it's been so deeply rooted in our community, it takes more than just a therapist or a psychiatrist to fix these things. It really takes us to be one, combined as a unit, connect as a unit to see what's really needed for our local areas, but also nationwide, and really employing those with lived experience to identify like, what are some policy changes we need to make a lasting change for races to be more equitable. And we know through some of the equity work, we can find the social justice equity work, we can find some sense of peace with racial trauma, but also requires individuals to own up to what role they have played to continue these systemic issues and systemic racist operations for people of color and people of marginalized communities, underserved communities.
So, our third thing that we'd like to discuss here when it comes to mental health is the shortage of culturally competent mental health providers. We've looked at the history, drapetomania, protest psychosis, the weaponization of psychiatry. How does that history, live and in the present, how does generational distrust affect the way Black Americans engage with mental health care today?
I think I mean, you mentioned culturally competent. I think also we really need culture responsive providers. Um,
Mhm.
Being competent in my community means that you understand, like, textbook what's going on. Being responsive means your practices mirror and match me where I'm at in terms of my community. So I think of like psychiatry. We think so often like um, there are studies for these medications that they're giving out. So there have been clinical trials that have been done with medication. And oftentimes we see like, individuals given high doses of medication where they're not able to function. And so when the mental health space has not been historically a safe space for people of color, they're often not willing to come into that space to get help, no matter how bad the symptoms may be. They will do things like self-medicate, with cocaine, meth, marijuana, alcohol, as a way, or sex as a way to deal with these emotions and feelings. And so I think some of the things you identified that has created a lasting impact for our community. And so there needs to be a way, as a holistic way, to identify like, how do we right this wrong, and having responsive providers is a big part of that, and being able to sit down and talk about the medication, not just, oh, you're feeling depressed, here's the medication, but talk through, are there other options we've done before prescribing medication? Because historically, people don't often like the feeling of being on medication, that they feel different, they feel numb, they feel like they're moving slower. What is the bedside manner for these providers when they're getting medication to explain to the patients, this will be your experience? Some patients who are needing medication, they think it's going to work tomorrow. It's like, it takes time to build on your system. But I often think that, because of the way mental health has been weaponized in the Black community, um, people are extremely more fearful of it. And so we have to be more patient when we're discussing new services and discussing how to integrate people into these services that they have not often taken up.
So, how does the lack of culturally competent providers affect diagnoses, treatment, and trust?
With treatment, we see it could be a lot of like misdiagnosing. So they may hear a few parts of someone's intake or some of their history and just throw a diagnosis out there. So it's not as rooted in their particular circumstance. They may not see like, oh, this is a trauma response versus, oh, this patient may be depressed, or this patient may be have anxiety disorder, or maybe substance use, or they're not understanding the whole circumstance of it. So it definitely impacts the treatment in the sense of like, patients are being misdiagnosed. And with the patients being misdiagnosed, and also like with the medication piece as well, if you're misdiagnosing somebody, you're prescribing a medication that's for this condition, but that may not be the right thing. And oftentimes, if you're on the wrong medication, that could lead to other long-term effects. And then also, if it's not working and it's not addressing the symptoms, then those patients may think the medication is not going to work, so they'll stop taking it and go back to self-medicating. But I think we see a lot of misdiagnosing with the Black and Brown communities.
So, with that, with those misdiagnoses, I mean, like, are there normally consequences for doing that, or does that just go as water under the bridge?
To the provider, are the
Yes.
consequences that are, I mean,
Yeah.
oftentimes, there aren't like real consequences, right? Because typically, if the patient is not satisfied, they may just stop coming to that particular provider, and so that provider may not never know they're misdiagnosed. And it's not until, and I've seen several patients, even in this current position, where they'll come in like, well, this doctor told me this doctor told me this. I don't know what it is, but I feel this way. And it's like you really want a diagnosis, not to be something that's happening after like a 15-minute conversation or a 5-minute conversation, in person or over the iPad via telehealth. You really want to be a conversation where they're doing a differential diagnosis. They may be comparing two different things and trying to weed certain things out to identify your actual lived experience and giving you time to share what your story is. I think oftentimes the providers are very rushed. And so you really want that diagnosis to be something you're comfortable with, and that provider to explain, why are you diagnosing me with, depression, not anxiety? Or how do I have like PTSD, but not the, like, you really want the provider to be able to explain it to you the same way you would like a mechanic explaining to you what's wrong with your car and why it's like the spark plugs and not the radiator. You really want them to have that context to really give you the information because you deserve that. And you are able to ask questions and kind of, if you need to challenge certain portions of that, you can do that if they're walking you through it. But oftentimes, patients are given a diagnosis, oftentimes with discharge. It's just on the paperwork, and they're just leaving to go, oh, I didn't know I had this. So you really want that to be part of the conversation. Yeah, it's frightening. It's really frightening. Depends on some clinics. It could be really scary the way their practices
So,
can be.
can you share some examples of how cultural misunderstanding leads to misdiagnoses or inadequate care?
Cultural misunderstandings can lead to misdiagnosis or inadequate care. I mean, the first thing that comes to mind oftentimes as a black man, especially someone who's gone through like grief and like who may have some like unresolved traumas.
Mhm.
If you see these individuals coming into the hospitals like that, they may be shut down. They may be guarded. And because of that guardedness, they're not asking the questions about, have you experienced a loss recently? Have you experienced any of these symptoms that may be related to like a PTSD? And so they just may see, oh, this, even a taller statued person, oh, this person may be aggressive because like look how they're presenting. Look at, it may seem like, look how they're sitting there. They're not interacting with a nurse, or they're very short. And so they may not be willing to kind of like level the playing field with that person. Like, what's going on? What brought you into the hospital, really? Who are you living with? What's your support system look like? Ask us some of these hard-hitting questions. And I know I experienced that recently. I was talking to a patient, and historically, he has not disclosed his substance use. In previous intakes, it's just nope, no drugs. And I'm just like, well, are there any substances in your history, or have you tried anything? And through that conversation, and just really being warm and open to them, like, oh yeah, meth, marijuana, a little bit of cocaine. So when you create a safe space for people of color, like oftentimes they'll kind of confine you a little bit more. But it often that's a really critical time, especially when they're new into the hospital or into a clinical setting. But yeah, so I think just taking someone off of face value can lead you to not hear what they're saying. And they may be telling you a lot in very few words. It may not be as expressive, but just because someone's not crying doesn't mean they're not depressed. Just because someone's not jumping around doesn't mean they're not anxious. It could be some more cognitive things they're focused on in terms of like they're overthinking and they're hyper focused on certain situations they can't control sometimes. But oftentimes, if you see some of the patients and they're appearing guarding, that could lead them to be misdiagnosed and or treated differently, if they're not always so bubbly.
So, why are so few black and brown clinicians entering the mental health field, and what barriers exist?
One, I think mentorship. So I think when you see like psychiatrists, therapists, social workers, those who work in the mental health spaces, like you really want to also professionally see yourself as someone who's done the work. If you have experiences where you're getting guidance and leadership from people who are non-black, non-Hispanic, not a color, their guidance is shaped through their white lens. And so it's a conflict when you're like, well, I'm learning this and I know how this feels for me and my spirit. You're saying the opposite. That's uneasy. And oftentimes, if you have those individuals in leadership, they often dictate the systems and structures of how things are happening to where you have a lot of people who are going into spaces and leaving because, like, it's not healthy at this point for me as a provider. It's not healthy for me as a social worker to lead and be here as an employee when my leadership is so anti everything I stand for. So it becomes a barrier. And also, we have schools, and depends on the criteria for admission for some of the schools. Like, are we are we doing things in the best interest to get a well-rounded, diverse class population? Oftentimes we're not. Oftentimes it is just individuals who, you want, certain criteria that often don't meet some of our Black and Brown communities. So how are we meeting them where they're at? So I know there's a lot of schools that are intentional about making sure that they are doing the work and in an equitable lens, not equality, but equitable lens to make sure the incoming therapists, social workers, psychiatrists, doctors represent the communities they'll be serving in or learning in.
Mm. So, that sounds like an ethics issue to me. Is
Yeah.
that where that falls under, or is there something else?
I definitely think it's ethics in terms of like doing what is right. And oftentimes people get into some of these positions of power and everyone answers to somebody, and the people they're answering to may not hold that as a high value. But I definitely think ethically you want to do that because, like, to have a school, have a system in a Black and brown place, but the students at that institution don't represent the community that they again will be ideally working in is a disservice ethically as well. So that's because we know the need for representation within these medical spaces.
And so, just if you could give us a summation here as to about the cultural competent mental health providers here for this section, I would definitely appreciate that as we get close to our time here.
Yeah, so again, we need more representation of culturally competent and responsive providers in our communities. We know oftentimes that the the health and longevity of that community is dependent on it from a holistic standpoint, medically and mental health wise as well. And we know we need to be able to provide patients with things they need and people that can represent them and understand their lived experiences. And that comes with having culturally competent and responsive providers from an academic space as well as a healthcare space, making sure that schools in those areas are bringing on and have criteria for students that look like those that they serve in the community, but also the healthcare spaces to where they are hiring, and making sure they're outreaching to the schools and stuff like that who can provide a candidate for a role that will look like and mirror what they need for their patients, both credential wise as well as culturally.
Well, so in closing here, Dr. Mosby, can you please, leave for our audience, especially those that are in your area out there in the California area, how can people connect with you and reach out to you if need to have not just assistance, but how to get some real serious mental health treatments?
Yes, absolutely. I think the best way is I'm naturally on LinkedIn, Dr. Leon Maltzby on LinkedIn, as well as on Instagram, Dr. Maltzby on Instagram as well. Easy way to get to me. I also operate a Instagram page called Black Men's Guide to Mental Health. And so I can always provide that, and you can put it maybe in description somewhere. But where I have a lot of people who are doing the work within the community. So even in California as well as other states that are connected to mental spaces. So those are probably the best three mediums to connect with me. And I look forward to any kind of further collaboration as well.
Well, thank you so much for what you have just helped us with as we get through another part of healthcare in the underserved communities. So, what I like to do now is I want to thank each and every individual for being here. I appreciate your time, especially the people that are here with us each and every time we do a show. But just in closing, I want to leave you guys with these words. If you stayed with us through this conversation, thank you. I mean that because this was not an easy episode. It was not designed to be. Easy conversations don't change anything. And the things we talked about today, the history, the trauma, the stigma, the systems that have failed generation after generation, those things demand more than ease. They demand honesty. And you showed up for that. So let me say this plainly, without qualification, without asterisk, without exception. Mental health is health. Full stop. Not a luxury reserved for people with the right zip code, the right insurance card, or the right skin color. Not a weakness, not a burden to be hidden under stoicism and prayer and perform strength of health. Health and human rights that every person in this country. Health is a human right that every person in this country, regardless of race, income, or geography, is owed by a system that has for so long, too long, looked away from the communities that need it most. I know this episode stirs something. I know some of you recognize people you love in this conversation. I know some of you recognize yourselves. Good. That recognition is the beginning of something, not the end of something. We're not done. In part 3 of this series, we go deeper into the structural and systemic architecture of healthcare inequality, insurance systems, economic barriers, geographic deserts of care, and the institutional neglect that spans every dimension of healthcare in underserved communities. Because mental health does not exist in isolation. It lives inside the same broken system we've been fighting since the beginning. I'm your host, Charles King. You guys have a great evening, and we will see you next Saturday